Welcome to myeyeacademy.com. I'm Professor Mahfouz Hussain from Pakistan. Myeyeacademy.com is a platform for ophthalmic teaching for everyone. In this video, VHB Chapter 10, Section 3, we're going to discuss open-angle glaucomas. So before we classify, we need to understand open-angle and close-angle glaucoma. Both these eyes have got open angles. Look at the angle here and look at the angle here. If the angle is narrow like this, now that's a closed angle or a narrow angle. If this eye develops glaucoma, that's going to call closed angle glaucoma. And if this eye develops glaucoma, that's going to call open angle glaucoma. Now how would you classify them? The open angle glaucoma, or also known as chronic simple glaucoma, can be divided into primary open angle glaucoma and secondary open angle glaucoma. Same is the angle closure glaucoma that can be divided into the primary and secondary angle closure glaucoma. Primary is when the cause is not known, and secondary is when there is a cause that is predisposing the eye towards the glaucoma. So let's see that in a bit more detail, the open angle glaucomas. This slide and the next slide are very important in the whole talk. We are going to discuss the mechanism or etiology of open angle glaucomas. Now, when the intraocular pressure is increased in the eye, there could be two reasons. One is that there could be increased production. Second is there could be decreased drainage. So if either the production is increased or the drainage is decreased, the pressure is going to rise. Practically speaking, reduced trabecular drainage is the main cause for the open angle glaucoma, whether it is primary or secondary. So remember again, reduced trabecular drainage or more resistance in the trabecular meshwork is the main cause for the open angle glaucomas. Now treatment is either you reduce the production or you increase the outflow. So that's the whole story about the glaucoma. After understanding that the reduced trabecular drainage is the main cause for open angle glaucoma, we need to move forward and a very important next slide. In this slide, we'll discuss the open angle glaucomas. Look over here, the angle is open, while here the angle is closed. So forget about the closed angle and we will only concentrate on the open angle. Open angle glaucomas can be primary or can be secondary. What's the difference between these two? In the primary, the cause is unknown, while in the secondary open angle glaucomas, either the pigment is blocking the trabecular meshwork, or pseudo exfoliation is blocking the meshwork, or the blood cells or inflammatory exudates are blocking the meshwork. So in the secondary glaucoma, something is blocking the trabecular meshwork, while in the open angle glaucoma, the cause is unknown and resistance increases in the trabecular meshwork. So this is the main difference between primary open angle and secondary open angle glaucoma. So look at the mechanism, increased resistance in the trabecular meshwork, and here the blockage of the trabecular meshwork causing resistance. Treatment is same for both of them, same principles. Medical treatment followed by the laser treatment, followed by the surgical treatment, and that we'll discuss in the next two slides. This shows that the reduced trabecular drainage is the main cause for open angle glaucoma, whether it is primary or secondary. After knowing the etiology that the reduced trabecular drainage is the main cause for the open angle glaucomas, we'll discuss the treatment. Treatment is very easy and very logical. Either you reduce the production or you increase the drainage. So it's very, very simple. Either decrease the production or increase the outflow. So how we are going to decrease the production? There are different drugs used. One of the beta blockers, lactimolol, is a beta 1 and beta 2 adrenergic blocking agents, and they reduce the production of the aqueous humor. Second is the carbonic anhydrase inhibitors like acetazolamide. The mechanism is it reduces the aqueous production again. And the third one is adrenergic agonists like bromidine and adrenaline. They cause the vasoconstriction to reduce the production, and they also increase the outflow by their agonist action. So once we know that we can reduce the production by these three type of drugs, we can use the parasympathomimetic like pilocarpine. The mechanism is cholinergic supplementing acetylcholine effect, and what it does, it causes the ciliary body contraction, which in turn opens the trabecular meshwork and the outflow increases. And another set of drug is prostaglandin analogs like xalatan, and the mechanism is increased uveoscleral outflow. So now we understand that we can reduce the production or we can increase the outflow. Decreased production is by beta blockers, carbonic anhydrase inhibitors, and adrenergic agonists, while the increased outflow can be done with the parasympathomimetic drugs or prostaglandin analogs. So if you have to combine two drugs, you can take one from this set and one from this set because they have got different mechanism of actions and they will augment each other. Now, if the medical treatment is not sufficient, you have to add more, and what else you add? You can either do the laser treatment or you can do the surgery. In the laser treatment, what you do is you use the argon laser, and the argon laser is applied to the trabecular meshwork, and the procedure is called laser trabeculoplasty. How it works? Laser causes scarring at the trabecular meshwork, which in turn opens the trabecular meshwork and the aqueous outflow increases. The surgical treatment is by a procedure called trabeculectomy. In trabeculectomy, we make an alternative route and the aqueous drains through that alternative route into the subconjunctival space and then gets evaporated. So we will discuss the steps of trabeculectomy in the next slide. Trabeculectomy steps: you do the peritomy, which is you lift the conjunctiva, like the conjunctiva is lifted in this area. Then you do a partial thickness scleral flap. Then a deep sclera is excised to create the new channel. You do the peripheral iridotomy, like you can see the black one here, and then you suture. You can see the sutures here, and the conjunctiva is sutured again. So this is the whole procedure, and you can watch the whole procedure in the video VHB 18.7. We've already discussed that the glaucoma can either be open angle when the angle is open or closed angle when the angle is closed. Now the open angle glaucoma, also known as chronic simple glaucoma, can either be primary when the cause is not known or the secondary when the cause is known. In the next few slides, we will discuss first the primary open angle glaucoma and then the different types of secondary open angle glaucoma. First of all, we'll discuss the primary open angle glaucoma. Remember from the definition, high intraocular pressure, disc cupping, and nerve fiber damage. For the high intraocular pressure, you need to do tonometry. For the cupping, ophthalmoscopy, and for the nerve fiber damage, you need to do visual fields and OCT. Now remember two other things. Patients should have an open angle, and there should be no known cause to label the patient as open angle glaucoma. The rest of is all of the rest is MCQs, so you need to concentrate on that. Incidence is usually in the 6th decade and onward. Both genders are equally affected, and it's usually a bilateral condition. The risk factors are more the age, more the chances of open angle glaucoma. If you've got a family history, first degree relatives have got the open angle glaucoma, you have got more chances of getting open angle glaucoma. Myopia, African blacks, and patients with diabetes have got more chances of getting open angle glaucoma. Etiology, the genetic basis, so the family members are at more risk. Mechanism we have already discussed, increased resistance in the trabecular meshwork. Treatment is medical, laser trabeculoplasty, and trabeculectomy. At the end, remember the associated ocular pathologies. The patient with the primary open-angle glaucoma may have myopia, retinitis pigmentosa, retinal vessel occlusions, retinal detachment, Fuchs endothelial dystrophy. Now we'll move to secondary open-angle glaucomas in which the cause will be known. And first of them is pseudo-exfoliation glaucoma. Pseudo-exfoliation is a type of secondary open-angle glaucoma in which the cause is known. And what is the cause? Cause is the pseudo-exfoliation. Remember again, high IOP, disc cupping, nerve fiber damage along with open angle, and the cause is pseudo-exfoliation. What is pseudo-exfoliation? Pseudo-exfoliation is an amyloid-like material which gets deposited everywhere. You can see in this diagram the whitish deposition at the edge of the iris and the lens, and this material is called pseudo-exfoliation. The pseudo-exfoliation material gets deposited in the angle and blocks the trabecular meshwork. So the only difference between pseudo-exfoliation glaucoma and primary open-angle glaucoma is that here we know that the pseudo-exfoliation material is deposited and blocks the trabecular meshwork. Diagnosis is high intraocular pressure, disc cupping, nerve fiber damage, plus you see the dandruff-like pseudo-exfoliation material on the lens, pupil and angle, like you can see it here. And the treatment is the same: medical treatment, laser trabeculoplasty and trabeculectomy. We move on to next type of secondary open-angle glaucoma. Pigmentary glaucoma is another form of secondary open-angle glaucoma. Again, it's diagnosed with high IOP, disc cupping and nerve fiber damage, open angle, and the only difference from the primary open-angle glaucoma that the cause is known, and it is the pigment dispersion. How does that happen? Rubbing of the iris posterior pigment layer against the zonule. This rubbing causes release of the pigment, and there are transillumination defects in the iris that you can see in this diagram. So this pigment gets deposited in the trabecular meshwork and causes increased intraocular pressure. For the diagnosis, along with the IOP, disc cupping and nerve fiber damage, you need to see, or you should see, pigment cells on the lens, endothelium and angle, iris transillumination, like this is the iris transillumination defects, along with the basic signs. Treatment is medical, laser trabeculoplasty and trabeculectomy, as it was for the open-angle glaucomas. Third is inflammatory glaucomas, another type of secondary open-angle glaucoma. Here the same increased IOP, cupping, nerve fiber damage, open angle, and the cause is inflammation or uveitis. What happens? The inflammatory exudate that you can see here as a white inflammatory exudate into the anterior chamber that blocks the trabecular meshwork, and the glaucoma resolves when the uveitis is treated. Diagnosis is same: IOP, disc cupping, nerve fiber damage, open angle, plus signs of uveitis in the anterior chamber. Treatment is the same as for other open angle glaucomas: medical, laser and trabeculectomy. Thank you very much for being with me, and please do give your feedback at the end. Thank you.